Welcome to the Ross University School of Medicine Procedural Skills NG Tubing lecture presentation. I'm Dr. Brenton Otey, and I will be guiding you through this lecture today. So, let's go ahead and take a look at our objectives. We're going to start by defining the NG tube and its purpose. We want to familiarize students with the indications, contraindications for NG tubing, and of course, some possible complications as well. We also want to teach students about the technique of the NG tube placement, and lastly, explain post-insertion management of the NG tube. Let's begin. So, what is the nasogastric or NG tube? Well, the nasogastric tube is a plastic tubing device that allows delivery of nutritionally complete feed directly into the stomach, or could be used for the removal of stomach contents as well. Note that there are other enteral, meaning directly to the gut, tubing methods. There's nasoduodenal, ND, and nasojejunal, NJ, both of which are to be used if feed directly into the stomach is for whatever reason contraindicated. However, these methods are more rare and often involve placement by a specialist. So, let's discuss some of the indications for NG tubing. For one, feeding purposes. Patients that are malnourished or at risk of malnutrition have an adequate or unsafe oral intake, but still have a functional accessible GI tract. Those patients include stroke patients or some other neurological condition which may cause dysphagia or unsafe swallow, patients in a coma or post-vegetative state, and of course, patients status post upper GI surgery where there's anastomosis that needs to be protected in the initial post-op period. Another reason for NG tubing is medication delivery. There's a plethora of medications that need to be delivered directly into the stomach, and an NG tubing is a safe and convenient way to get this done. Some more indications include, as discussed previously, removal of gastric contents as well. It can be used for gastric decompression, perhaps symptom relief and bowel rest for patients with a small bowel obstruction, and also for aspirating ingested toxic material. Another great indication for NG tubing is of course for diagnostic purposes, perhaps for the assessment of the presence and the volume of an upper GI bleed in a patient, or for administration of radiographic contrast for radiographic imaging studies. Now, let's discuss some contraindications to the NG tube. There's two different types, absolute and relative. Absolute contraindications meaning under no circumstances should this patient be subjected to an NG tube. Those include patients with mid-face trauma, as that would be the tract by which the NG tube has to pass and could result in further injury, and also patients with recent nasal surgery for the same reasons. Now, some relative contraindications. In the presence of relative contraindications, you must weigh the advantages and disadvantages of an NG placement versus the reason for tubing versus the patient's current condition. And these would include patients with abnormal coagulation status, recent alkaline ingestion, esophageal varices, and esophageal strictures. Now, let's talk about NG tube placement itself. But first, we have to gather our necessary equipment. Here on the slide listed, you will see some of the necessary equipment which will be needed for the procedure. Of course, the nasogastric tube itself, preferably 16 to 18 French in size, a cup of water with straw, some tape to secure the tube after placement, a pH indicator, some gloves, an emesis basin, a benzocaine spray, or water-based lubricant, both of which for patient comfort, and suction, in case of vomiting, especially in patients with a decreased level of consciousness. Now, let's discuss patient positioning. In order to place the nasogastric tube, positioning for the patient should be sitting upright. The neck should be slightly extended. Extending the neck allows for the nasal canals to be on a horizontal plane, which is easier for visualization. And then, of course, we want to support the head. You can use a pillow to support the head. You may need additional assistance for a patient that is unconscious. And then pictured here, we see a properly placed NG tube and how it feeds directly from the nasal, the nares to the stomach. Now, there's 3 components of placement technique, which we're going to discuss in this presentation. And these are the 3 main processes: preparation, insertion, and then post-insertion. So let's move on to NG preparation. For nasogastric preparation, first and always you want to discuss the procedure with the patient, explaining the indications, complications, and alternatives, and obtain consent. Next, you're going to want to assemble the equipment and take to the patient bedside. Before we touch the patient, of course, we're going to wash our hands and glove up, and then position the patient as we already discussed, sitting upright, neck slightly extended, and supporting their head. We're going to examine their nares and identify which one is more patent, as that is the one that we will use for the NG tube. And of course, apply local anesthetic spray to the back of the patient's throat for their comfort, as when you're placing the NG tube, it may cause a slight discomfort without it. And then pictured, we have a nice example of an NG tube, just what it looks like. Continuing on, we want to measure the NG tube. And lastly, we're going to lubricate the tip of the NG tube using either a water-based lubricant, or you can simply just use water. The next component is the actual process of insertion. First, you're going to insert the tube into the patient nostril, advancing along the base of the nasal canal, directly horizontal towards the nasopharynx. When a resistance is met at the back of the nasal canal, advance the tube gently as it curves downwards to the pharynx. Remember, never force the tube if meeting significant resistance. Twisting the tube will also help as you advance. Ask the patient to swallow a sip of water as you advance from the back of the nasal canal to help naturally ease the nasogastric tube towards the esophagus. Now you may be asking yourself, well, when do we stop advancing during insertion? Well, let's talk about it. Stop whenever the distance marker on the NG tube is reached, or the following situations: if the tube emerges in the oral cavity of the patient, if the patient experiences respiratory distress, or if they're unable to speak, in the event that the placement of the nasogastric tube causes a nasal hemorrhage, or if the tube meets significant resistance. Now, let's discuss some possible complications of nasogastric tube placement. There's vomiting. You could stimulate the gag reflex of the patient. Malpositioning, coiling, or knotting of the tubes can occur anywhere along the course of the tube, including the pharynx, piriform sinus, esophagus, stomach, and duodenum. Pharyngeal and piriform sinus misplacement can be recognized in a patient who complains of significant gagging or emesis. You could also inadvertently cause aspiration secondary to incorrect placement of the nasogastric tube, not into the stomach, but into the respiratory tree. The risk for pulmonary complications is increased in patients with nasogastric tubes. Avoidance of prophylactic postoperative nasogastric decompression decreases pulmonary complications and has other beneficial effects. Intubation of the lung and inadvertent administration of medications, radiocontrast media, or enteral formula through the mispositioned tube could lead to pneumonia, pulmonary abscess, or even tracheal perforation and pneumothorax have also been reported. The tube itself could also cause direct tissue trauma along the nasal or pharyngeal or upper GI tract. Nasal alar ulceration or necrosis could occur from improperly securing the tube or placement of too large of a tube in an unconscious patient who cannot really convey their discomfort, which can lead to pressure ulcers and even alar necrosis. Perforation, lastly, is a huge complication possibility of NG tubing. In addition to potential perforation of pulmonary structures or the GI tract, nasogastric and nasoenteric tubes can perforate other structures in patients with certain pathologic conditions. Patients with prior esophageal or gastric surgery are at risk for GI perforation, and infants, children, and patients with facial trauma are at risk for cribriform plate perforation and intracranial intubation. Now, we've inserted the tube. The last component is post-insertion management. What happens next? Well, before removing the guide wire, we're going to aspirate from the NG tube and check for the gastric pH, which should be acidic, between 0 and 5, using the pH indicator. This would indicate that we're actually in the stomach and not somewhere else, such as the respiratory tree. If the pH is confirmed, we can remove the guide wire and then secure the tube in place with the tape. If we're unable to aspirate from the NG tube, do not remove the guide wire and tape the wire in place. We also want to attach a drainage bag, also known as a spigot, as appropriate, to the end of the tube and secure for patient's comfort. If we're unable to confirm placement via the pH test, we can also confirm it with a chest x-ray. We have 2 examples of NG tube placement on the slide picture here, one correct and one incorrect. So starting with the image on the left, we can see that the nasogastric tube correctly passes through the esophagus and ends in the stomach. And then on the right image, we can see that the nasogastric tube does not pass through the esophagus and end in the stomach as it should, but it actually goes through the respiratory tree. As you can see, the contents leaking out in what would be the bottom right lobe of the patient's lung. Lastly, and most importantly, we want to reassess regularly whether the need for the NG tube is present or not. The function of the nasogastric and nasoenteric tubes should be checked frequently by irrigating the tube with water about every 4 to 8 hours.